Hello, dear viewers, and we're back again right here at Good Morning Kuwait after that report. So today we dive into some of the most common digestive issues people face, which is acid reflux, ulcers, and post-bacteric symptoms to understand their causes, risk, and how to manage them with proper medical guidance. And now we are going to welcome Dr. Shamlan Alqinai, who is a specialist upper GI hernia and general surgeon right here at our show. And good morning and hello and welcome to the show, doctor. And how are you?
Thank you for having me. Thank you so much.
All
Thanks
right.
for having me.
You're welcome anytime. So could you tell us what's causing the rise of basically of acid reflux amongst the patients?
So most patients that come to my clinic, they're usually complaining of heartburn, reflux symptoms. Modern habits is what is causing most of the problems we see today. So eating a heavy meal before bed, eating high fat meals, obviously smoking, and we've been seeing a lot of reflux in heavy set individuals, so obesity.
All right. So what are the common lifestyles that basically causes this?
So as I mentioned, eating before bed, having a weight or a BMI, a body mass index of more than 30, that's also risk factors. Smoking causes some relaxation or involuntary relaxation of the valve that's between your food pipe and your stomach. So these are the main risk factors, and there are some medications that also cause the reflux symptoms.
When you say the relaxation of the valve in the heart, what does that mean, and what does it actually cause that is also predominant with the acid reflux?
So between our food pipe and our stomach, there is something we call the gastroesophageal valve, which is basically a valve that helps regulate food intake into your stomach. So there are some risk factors that causes an involuntary relaxation of that valve, which results in reflux. So we've been seeing it a lot recently, especially in the modern days, when patients are on the heavier side, so obese patients. So that's pretty much what that means.
So how can we actually know the simple feeling of heartburn from GERD?
So heartburn is an occasional symptom. It means that it happens maybe once in a while after a heavy meal. The patient may find some burning sensation behind his chest bone. When we say GERD, it specifically relates to a disease called gastroesophageal reflux disease. That's a more persistent type of condition. It has a specific spectrum. Some patients may have symptoms on a daily basis. Some patients may have it on a couple of times a week. So that's where they go into that spectrum of disease.
Usually, like, I don't know if it's a misconception, but usually they always tell if you feel heartburns or GERD, just take anything that has dairy, like something that has healthy bacteria or yogurt.
So that's a misconception. You might feel better at the time of drinking that colder drink or a dairy, but actually that may precipitate the problem shortly after.
All right. So when does reflux become dangerous, or when do we actually feel that this is the top of the climax of the feeling and it has to be assisted?
So reflux, patients that have reflux for more than 5 years, usually that's one of the alarm signs. So they have to obviously get an endoscopy, which is a camera, just to make sure that the esophagus or the food pipe looks okay. So if the patient has related weight loss, that's involuntary weight loss, so they're not trying to lose weight. If the patient has a persistent chest pain, or they are have chronic cough, or God forbid they're having some sort of blood that they're bringing up, or in the toilet, that's when we consider it to be on the dangerous side. Or if there's objective evidence of esophageal damage, which means during the endoscopy, when they take a look at the food valve, that it may be ulcerated, or some specific changes related to a condition called Barrett's esophagus.
All right. So some people actually do have a scares to actually put something in their mouth for inspection. So how can we raise awareness that this is something, it's a procedure that is simple and it can happen, and it takes a few minutes?
So it's a harmless procedure. It's extremely safe. We have I work very closely with our gastroenterology colleagues who do this all the time. It's a day case. It doesn't take more than 5 to 10 minutes. Patients get a quick endoscopy. I would recommend patients get that endoscopy if they are at higher risk, which means that they have severe reflux despite medical treatment.
All right. So let's move to stomach ulcer, and what are the main reasons for it?
So the main, the three categories is non-steroidal drugs, which means medications that may treat joint pain. Patients may take it over the counter without consulting a physician. Second thing, we have a very specific bacteria that's found in the stomach. We've been seeing a lot of it in Kuwait. It's called H. pylori. It causes mucosal damage, or the inner lining of your stomach gets damaged after some time.
What is the cause of that bacteria being now common here?
There's no specific cause, but there's a multifactorial environmental cause, and some patients may have it, especially if they're on medications that suppress acid. Especially if they're taking it long term. And of course, the third cause would be smoking.
All right, cool. So what does coffee truly contribute in this?
So coffee, there's been this misconception that coffee causes ulcers. Coffee does not directly, or hasn't been directly related to causing ulcers. But if a patient has an existing ulcer or ongoing inflammation, then coffee will precipitate or irritate that. So coffee does not directly cause ulcers.
But the acid in it, that's the thing that people actually say that it's very high in acid. And I think it gives you the same feeling or sensation of having ulcers.
Absolutely. So if you have an existing problem, it may make it worse, but it doesn't directly cause it.
All right. So acid suppressing medications. What happens if using it in a long term?
So there's a lot of talk about that recently, and a lot of people may take those medications over the counter without consulting a physician. So long-term use has been associated with some mineral and vitamin deficiencies, has been proven to have some effect on bone mineral density, so may cause something called osteoporosis or thinning of the bones. In patients with pre-existing kidney damage, it may precipitate some kidney problems. And there has been some association between their use and developing some sort of GI infections.
And when can we actually tell to patients to stop relying on it?
So I would advise all patients who are on high dose of those medications. So for example, if they started off at a low dose and then found themselves a few months later still having the symptoms, increasing their dosage but without consulting a physician, I would recommend them to see someone. Or if they have what I mentioned earlier, which is the alarm signs, I do recommend them seeing a specialist in that field.
All right, so going back to obesity, and we know obesity causes a lot of diseases, and one of them is reflux and GI issues. So how can we mitigate this and try to...
So obesity, obviously we have multiple ways to treat obesity these days. There's the medications, there's the surgical, there's endoscopic, or through the use of a balloon. The thing is, obesity by itself contributes to an increased intra-abdominal pressure. So that pressure spreads along the gradient of the valve, and it increases gastric reflux in that indirect way. Also, obesity, just the adipose tissue, is hormonally active. So that means that it causes a relaxation of that valve. Now, having said that, 50 to 60% of patients who are obese have something we call a hiatal hernia, which is a hernia around the esophagus or the food pipe. So those are the patients that I would recommend them seeing a specialist in that field. And most of my patients that walk into my clinic fit that criteria.
All right. So we're talking about obesity, and what is actually the mechanism that actually makes symptoms even worse because of obesity? And there are some actually people that are obese, but they live kind of a okay life, as you say.
Absolutely. So as I mentioned, increase of intra-abdominal pressure, or in the pressure in the tummy, causes reflux. That's number one. Number two, obesity decreases gastric emptying time, so the stomach doesn't empty the same way as maybe a lighter patient would empty. And thirdly, that, as I mentioned, 40 to 50% of them may have a hiatal hernia, which disrupts the reflux mechanism or the anti-reflux mechanism. And then the last thing, just the fact that the tissue itself is hormonally active, may secrete specific hormones that reduce the tone of the valve itself. So there's it's a multiple it's multifactorial in those patients.
It's kind of like a chain of reaction that goes on.
Absolutely,
yeah.
yes. Absolutely.
And the thing is that chain reaction, it doesn't go in one specific direction. It does sometimes vary and goes up and down or branches out.
100%.
Yeah.
Yes.
So is reflux after bariatric surgery normal or a warning sign?
So again, a big subset of my patients are patients who did, for example, a sleeve gastrectomy years ago and are complaining of reflux now. So it's I wouldn't say direct correlation, but 30% of patients undergoing bariatric procedure with existing reflux may make the reflux worse. So those patients, it's not a direct correlation, but yes, you can develop reflux after sleeve gastrectomies. On the other hand, I see patients who had this procedure and have zero reflux symptoms. So it really depends on the patient.
All right.
Yeah.
And what are the urgent evaluation that you should do after the surgery?
So depending, as I mentioned, there's different types of procedures. Every procedure has alarming symptoms. So if there's any increasing tummy pain, if there's a fever at home, if there's persistent vomiting, I would definitely recommend these patients to be seen urgently by a specialist or a specialty hospital.
All right. Thank you so much for actually having us for today right here at Good Morning Kuwait, and we hope that we do see you again, doctor.
Thank you for having me. Welcome. Appreciate it.
All right, dear viewers, we've reached to the end of right now the first guest right here at Good Morning to Kuwait, and now we're gonna basically go to our another report, and we'll be right back right here at Good Morning Kuwait.